Dedia. On behalf of Sun Pharma, I welcome all the respected doctors for the today's scientific advisory board meeting. The objective of the today's meeting is to understand the patient profile for the use of desidustat in the management of anemia associated with CKD. With the help of the series of the cases that we are going to present here, we have the doctors to present the case, and after each case we will have the discussion among all the doctors. So at the outset, I welcome all the doctors for this meeting. I thanks Dr. M. Edwin Fernando sir to accept our invite to moderate the meeting, and thanks all the doctors for attending this meeting. This is the agenda of the meeting. So we will have first presentation by Sun Pharma. I'll present for the 10 minutes about the desidustat use in anemia and CKD, followed by the we have the cases, 5 cases, and after each case we will have the discussion. So before we start, I invite Dr. M. Edwin Fernando sir to set the context of meeting. Over to you, sir.
So thank you and welcome to all. So let's all accept that anemia is not very abstract to us. Almost all our patients, whether in the OP or IP or whether it is CKD or AKI or somebody who is critically ill, anemia is something that we see every day. And it's been a huge challenge treating anemia. As such, anemia is common in our country. So if you look at many female patients, their hemoglobin, even not patients, even normal people would have a hemoglobin of about 10 to 11, and many times you'll have to ask them whether they had a recent period. So for us, it's a huge burden, considering the fact that it affects quality of life, it causes exhaustion, cardiovascular mortality, etc. So after a huge gap of nearly 12 years, the KDIGO comes out again only in 2026. The previous guideline was in 2012. With a fresh set of guidelines where there are a lot of changes in the anemia management as far as iron therapy is concerned, number one. And of course there is a component of the HIF-PHI that we are talking about, that we're going to talk about today. And for the Indian context, it is a little different because our problems are different. The cost for healthcare is different. We have different sectors of healthcare. We have the government on one side, then we have the corporates, then you have the middle level hospitals, then our patients are there in every sect of income. So for us, looking into these guidelines, the local perspective is very important. So over the next few minutes, we shall discuss about the role of desidustat. Desidustat is a game changer in that all along we've been having only injectables, as it may be iron, maybe erythropoietin, and then there's patients who do have the injection phobia. So something like HIF-PHI is a oral drug for something that has always been a parenteral replacement therapy for iron, for hemoglobin. So in that way, it's a game changer. Plus, it's got a multifaceted role in that it can decrease the hepcidin, it can mobilize the iron stores, it has got favorable effects on the lipids. So all these other added advantages are there. So with this, with these few words, let me begin the discussion. Now I hand over to Rajneesh for his talk.
Yeah. Thank you, sir. So I will be quick to present the data so that we will have the more time for the discussion. We are well aware that the anemia affects around 13% of the population in India, and the CKD affects the 13% of the adults in India, and the anemia is the common complication with the prevalence of 39 to 60%. It's the prevalence as well as the severity increase as the CKD advance, and it adversely affects the cardiovascular outcomes and quality of life in anemia in CKD patient. The pathophysiology is multifactorial. the major pathophysiology is decreased endogenous EPO production, as well as absolute and functional iron deficiency, as well as the hepcidin deficiency is the inflammation, and the hepcidin deficiency, sorry, the hepcidin increment is the pathophysiology for the anemia in CKD. The current guidelines, as per the current guidelines, the oral or IV iron along with ESA are the standard of care for the management of anemia and CKD. The HIP PHIs are recommended in ESA hyporesponsiveness patients if there is a desire to raise the HP level and to avoid the blood transfusion and to improve the symptoms of the anemia. Although ESA is standard of care, there has been certain limitation to the use of ESA, such as ESA hyporesponsiveness observed reported in around 5 to 17% of the CKD patients. Then we need to increase the dose of the ESA that may adversely affect the cardiovascular complications. Also, the HP above the recommended target is reported in around 1/5 of the fifth of the dialysis patient, and apart from this, the parenteral formulation of the ESC is one of the limitation. So the patient inconvenience is one of the limitation with the ESA. So to address this limitation, the HIP PHIs were developed. So HIP PHIs improves the production of the EPO in physiological manners. It also improves the iron availability and reduce the hepcidin level, which is the major pathophysiology in the anemia of CKD. So this is the list of the HIP PHIs available globally. So we have daprodustat, desidustat, then we have the inerdustat, molidustat, roxadustat and vadadustat. The desidustat and roxadustat are the thrice weekly formulation, other are the daily formulation because of the difference in the T-half, and this desidustat and roxadustat, the thrice a week formulation is physiological to have the improves erythropoiesis at the same time to avoid the increase in the HP above the target. So this is the list of the HIP PHIs approved and available globally. If we talk about the mechanism of action of the desidustat, so HIP, that is hypoxia inducible factor, is the transcription factor involved in the erythropoiesis, and it is hydrolyzed with the help of the enzyme prolyl hydroxylase enzyme, which is involved in the hydrolysis of the HIP transcription factor. So desidustat and all the HIP PHIs inhibitor blocks the prolyl hydroxylase, they inhibit the prolyl hydroxylase and stabilize the HIP factor involved in the erythropoiesis, and that's why they improves the erythropoiesis and EPO, increase the EPO production in physiological manner. Apart from that, the desidustat suppress the liver hepcidin synthesis as well as increase the transcription of the factors involved in the production of the transferrin, which promotes the iron utilization. So these are the mechanism of action. I will present quickly the two landmark studies for the desidustat, DREAM-ND, which was done in non-dialysis setting, and DREAM-D, which was done in the dialysis setting. So DREAM-ND is the 24-week phase 3 RCT with the objective to assess the efficacy and safety of the desidustat as compared to dibepoetin in the anemia patients with CKD who are not on dialysis. So in this trial, 588 patients were enrolled and randomized into 1:1 ratio into desidustat and dibepoetin alpha. The patients were having the HB ranging from 7 to 10 gram percentage, eGFR more than 10, the serum ferritin more than 200 and TSAT more than 20%. These patients were randomized into desidustat oral tablet 100 mg thrice weekly, and another group received dibepoetin alpha injection 0.75 microgram per kg once in a 2 week. And the treatment was given for the 24 week, and at the end of the 24 week, the patients were assessed for the primary endpoint for the change in the HB at 24 week compared to the baseline, And the secondary endpoints were the HB responders, time to achieve the target HB range, percentage of the time spent in the target HB range, serum hepcidin, serum potassium, quality of life, the rescue therapy, and the lipid profile, as well as the vascular endothelial growth factors. These were the secondary endpoints. So the primary endpoints, the HB increment at week 16 to 24 week was 1.94 gram per DL with the desidustat compared to 1.83 gram per DL in the diabepoetin group. So the desidustat achieves the non-inferiority, and it is comparable with the diabepoetin group. The primary endpoint was achieved in this study. So out of the secondary endpoints, I would like to highlight the HB responder, which was significantly greater with the desidustat as compared to the dabipoetin. With the desidustat, HB responder is 77% as compared to dabipoetin, it is 68%. That is 77% of the patient could achieve the HB or in the target range or increment of the more than 1 gram per DL at the end of the study. Other parameters were comparable, like time to achieve the target HB range, percentage of the patient, percentage of the time spent in the target HB range. These were the comparable between the two groups. The decrease, the decrement in the hepcidin was significantly greater, that is significantly greater decrease in the hepcidin level with a desidustat as compared to dabipoetin at week 12 as well as week 24. If we talk on the adverse events were comparable between these two groups. The common adverse events were the mostly GI adverse events, then pyrexia, hypersensitivity, dyspnea, UTIs, headache, cough, and hypertension. These were the commonly reported adverse event in this trial. The adverse events were comparable. So this trial concluded that desidustat is non-inferior to dabipoetin in the treatment of anemia of CKD in non-dialysis setting, and it is well tolerated. Second trial is the DREAM-D trial, which was again 24-week phase 3 RCT, enrolled 392 patients and compared the efficacy and safety of desidustat versus apoetin. Patients were randomized into 1:1 ratio and given desidustat oral 100 mg thrice weekly, and another group was given apoetin alpha subcutaneously. And the endpoints were the same as that in the DREAM-ND trial. And again, the HB increment was 0.95 gram per DL with the desidustat compared to 0.80 in apoetin groups. The inferiority was achieved, and the both groups desidustat was found to be comparable with apoetin for the increase in HB range. Secondary endpoints, the HB responder were significantly greater with desidustat, 59% as compared to 48% with apoetin, and time to achieve target HB range were significantly lower with the desidustat, around 7 weeks compared to 9 weeks with the apoetin alpha. The adverse events were comparable between these two groups. So this trial concluded that desidustat is non-inferior to apoetin in the treatment of anemia of CKD in dialysis setting, and it is well tolerated. And based on this trials, the desidustat was approved in the anemia in adult patient with CKD, both in non-dialysis and dialysis setting. The available strengths are the 25 mg, 50 mg and 100 mg oral uncoated tablet, and the recommended starting dose is the 100 mg thrice a weekly. So with this, I hand over the session to Sir for the further proceeding.
Thank you, Rajneesh. You have given the literature review on the subject and also how the drug acts and all the advantages of using the molecule. My question is, if you read the literature, there's another drug called peginesetide, which actually came up to phase 3 trials but did not make it because of very high cardiovascular mortality. So after that, we got this drug much later, especially after the Peter Radcliffe was given the Nobel Prize for discovering this HIF mechanisms, oxygen sensing mechanisms, and that is how this drug came, and it is available to patients now. The US FDA took actually a very long time in approving the drug. In fact, Desidustat was available in India even before the US FDA approved. So in fact, I did not use it for a long time. And then when discussing with friends in US, they said they are still a little worried about the cardiovascular safety. So they took a very long time to review the literature and this data, and then to have a look at it again. And then I think only in February 2024 or something it was approved by the US FDA. So there were concerns, and there are still some concerns about the drug. So we'll take some case series now. Case Dilip, are you ready? Yeah. So you will speak on Desidustat, on CRP and other inflammatory markers. So I request you to be brief with your presentation. So, yeah. All right. You can tell us where you work, because a lot of new faces.
Maybe some of them I know.
Yeah.
I worked in Madras Medical Mission. I was in Middle East actually.
So relatively new to Chennai.
Yeah.
Yes.
Yeah. Okay. Yeah, almost a year now.
Yeah. So where did you train?
I did my DNB NFO from Manipal Hospital under Dr. Bellal.
Okay.
I know Dr. Georgie because I did my MD from Ramchandra.
Right.
So that time I was working with sir. So after moving from Middle East, actually I worked for the Dubai government for almost 16, 17 years.
Right.
I use this drug actually not Desidustat, Roxadustat, which was being launched during the post-COVID time actually. That time Astellas, they were one of the research thing. So it was very expensive that time. And the vascular complications were quite high.
With the Roxadustat?
Yeah, Roxadustat. So, but it was there also in Middle East also it was very expensive. But we used it because we used a few of our patients actually for this. That's the first time I had experience with. Desidustat after coming to India only I started using it actually. So, this common scenario we usually... how to? Here?
Yeah, that's the next one.
Yeah, normally we face in CKD stage 4, they come to us because with anemia, and most of the time we'll put them on dabipoetin, but the hemoglobin is not improving. Then we look at the iron studies. Then you see a high F13 level with almost the TSAT. CRP also will be elevated actually. So background history is diabetes CKD with hypertension and no history of any malignancy in the past. We put him on dabipoetin for once weekly for almost 2 to 3 months, and with oral iron, and the patient is already on ACE inhibitors and statins. Vitals are stable actually, no signs of any volume overload. So this is what we used to see with no improvement in the hemoglobin. So it just changed from dabipoetin to Desidustat. So the iron utilization was good. So most probably the functional iron deficiency, the TSAT also improved. The inflammatory markers came down, including the hepcidin level actually. So diagnosis was a CKD associated anemia with functional iron deficiency with some amount of inflammation. So this helped actually, this drug though helped with the improvement of the iron, improvement with iron and improvement of the hemoglobin. So that's what the DREAM ND study, which already showed that it improves and reduces the inflammatory markers and improves the hemoglobin in a setting of chronic kidney disease with elevated the reduction of the CRP and stabilization of the iron studies there. So the outcome was around improved in the hemoglobin, which not stabilized. That's one more thing we noticed is that because most of our OP patients, we usually see them once in 3 months. They once in 2 months actually. Once you put them on a dabipoetin, we can see the fluctuations of the hemoglobin, which I didn't find much with the Desidustat. No, there was no much of drug-induced adverse reactions, and follow-up also, we are able to maintain the hemoglobin with desidustat actually. And no overshooting of hemoglobin identified. So these are the key points. Basically, it can be used for the treatment of anemia with almost with an underlying inflammatory, high inflammatory setting with the functional iron deficiency. And the only thing is maybe with caution in malignancy, maybe because of the upregulation of VGF. That's one thing. Even if I don't use in Middle East, we are more worried about it because I don't use any dabipoetin on patients with underlying malignancy. I know. Yeah. We don't use it at all there.
Okay.
So when this team...
Is it some local guideline there?
Yeah, local guideline there that we don't use dabipoetin now. We usually use only dabipoetin there, but we don't use it for the malignancy. Here also I just practice that. So here also, this also is questionable to use in case of any malignancy. I think that's all.
Okay. Right. So again, this KDIGO 26 uses two terminologies. One is replace the two earlier terminologies. One is called the absolute iron deficiency. That is called systemic iron deficiency now. And that is characterized by a low TSAT and a low ferritin. Then the functional iron deficiency, that is now called iron restricted erythropoiesis. So these are the two terminologies that have been changed in this KDIGO 2026. So an iron restricted erythropoiesis, iron is not available. This is basically due to hepcidin. So do you think we should be monitoring these acute phase reactants on a regular basis? Maybe you did it in the Middle East, but I don't think that is practical in doing it in our setup.
Look at the CRP, but all the hepcidin levels and IL-6 at all, it's not practical.
Exactly, exactly. So one thing that has been shown in the studies is the decreased hepcidin level. And you all recollect the ion absorption pattern, the ferroportin that helps in transporting the oral ion from the duodenal enterocytes is controlled by the ferroportin. And this ferroportin and hepcidin are inversely in relation. So high hepcidin is going to inhibit the ferroportin, thereby the oral ion absorption is poor. Again, repeatedly we find sometimes writing erythropoietin is sort of a knee-jerk reaction in any CKD anemia. We still feel that there are nutritional deficiencies that have to be corrected before we start on erythropoietin. So do you think, considering the fact that in the Middle East you have a large dialysis population, so was roxadustat replaced dabipoetin?
No.
Yeah.
First and foremost, it was very expensive.
Okay. Okay.
And second thing is, see that dialysis population, I feel dabipoetin is still better because they are coming to us on a regular basis.
Right.
We can monitor the hemoglobin. There will be monthly monitoring hemoglobin here once in 2 months, so that we can see the fluctuations. OP basis, fine. Maybe patients refuses. So there, no, most of them, if you have injectable and a non-injectable, they usually
Prefer a non-injectable.
prefer a non-injectable.
That's right.
And we usually see them once in 3 months. I work in the government center getting a appointment is very difficult, so I see them once in 3 months actually. So there, no, I find it, the fluctuations, this is not, they were so promoted in such a way, fluctuations of hemoglobin I have not noticed with the roxadustat.
This hemoglobin cycling.
Cycling. But dialysis population, not much.
Okay.
And some of them have used with the combination of both to improve the hemoglobin. I don't have the evidence for
Right. There's no guideline combining both. There's no.
Price described this.
Huh?
When you want to increase it, it is not. We have tried. I have tried. And only have when you have tried.
Yeah. So sometimes we have personal preferences, but this also always be backed up with some evidence. Any other experiences? from yours. You can start. What is the patient's acceptance?
Acceptance is okay, especially if they don't want
Injectables. Right, right.
So,
Hmm.
or like even with high dose.
So is it licensed for pediatric use also?
For adult.
Yeah.
Decidustat
Hmm.
for adult.
Right. Oh, so you'll be a little careful there again.
And if they're not responsive to
Darby point.
Darby pointing, then we can add on this. That's a good idea.
So you're saying hybrid. You give some Darby and then give some decidustat. Okay. What about?
So I've noticed like a dramatic improvement in the hemoglobin initially, and then it sort of settles in flat.
Again, we are dealing with two populations. One is a non-dialysis population, where the response is a little better because the GFRs are still okay and still there is some erythropoietin production. But the dialysis population, do you feel that this may be useful or Darby may be better?
I think it is useful in the dialysis
Population also. Okay.
Personally, PD, I'm
Right.
experience from patients with PD.
Okay. So I have one basic doubt. If somebody is able to answer, I'll be happy. See, the mechanism of the drug is it stimulates endogenous erythropoietin release, right? Now, there is always there's a CKD and there's only fibrous tissue there, right? So what is this happening?
Liver is the another source. 10% of the erythropoietin production from the liver, 90% from the kidneys, and some amount of other foci are there. So maybe it stimulates the endogenous production of EPO from other sites. So more conversion in the bone marrow. Stimulates the bone marrow production of conversion of precursors.
No, that is under the effect of erythropoietin. The precursors will act only when erythropoietin acts. The precursors progress. So what do you think, Sandhya?
I think it's very similar to how glimepiride and insulin works. So up to a point we can stimulate the beta cells to produce insulin, and then after a point you have to give insulin in type 2
Right.
diabetes. It's something
Right.
similar to what I see in with erythropoietin. Up to a point, especially in dialysis population, to a certain extent, initially when there is some residual renal function, I think it will help, but then later on we may have to give a combination of
No. See, we don't have any literature support for hybrid therapy at all, right? So are we saying that it is more useful in the ND population only because the DREAM-D study shows that it is useful in the dialysis population also?
My take was, sir, that we really don't know what exactly is the endogenous erythropoietin production for every individual.
Right.
So everybody are CKD, everybody are on dialysis.
Right.
So there are certain people whose hemoglobin just is stable without even being on erythropoietin.
Right.
Some others need very high doses.
Right.
So when it's such an erratic distribution of endogenous erythropoietin production in everybody with on dialysis, maybe the ones who have that nature itself to have that extra erythropoietin may benefit from this drug versus the
Maybe is there a difference between interstitial disease and glomerular disease? Maybe. You want to
diseases in
CKD per se.
use that mic.
The erythropoietin is actually CKD per se. They do have a production, but it's suboptimal.
Correct.
So
Correct.
the relative to the anemia, it is
Yes.
suboptimal. Maybe
Yes.
that is what this helps to overcome. Probably.
Okay. Maybe it's worthwhile looking into observation. Correct. Maybe now the erythropoietin is believed to be secreted by the non-cells. They are supposed to be specialized cells in the interstitium. So maybe worthwhile looking at the differences in response. For example, somebody with polycystic kidney disease, generally the anemia is not that bad.
Yes.
Right. Maybe that's worthwhile looking at. So with this few comments, I'll ask Shiva now. Yeah.
CKD dialysis dependent population. Say somebody is on decidustat and their hemoglobin doesn't improve. Then what we obviously go back to
Correct.
Also, what's the risk of using it in heart failure patients? Like, they have anemia, chronic disease.
Okay. Provided that anemia is a normocytic normochromic anemia. Right. Because heart failure anemia may be again different etiologies may be there. So again, make sure it is normocytic normochromic anemia.
Even with history of CVS,
Yeah.
should we prefer
Strokes, polycystic disease, or somebody having proliferative retinopathy. So these are all, I think, areas of concern, and one has to be really careful while using this medication.
They have some vascular complications.
Yeah.
So which is preferable, sir? Which should be, as of now, we are not sure.
No, erythropoietin would be safe. At least it's a time-tested molecule.
Low dose erythropoietin.
Yeah. Why do you say low dose? We have to give an appropriate dose. Otherwise, your anemia is not going to get corrected.
High dose of erythropoietin. Definitely, actually, most of the studies to the anemia, cheat trial, create and fire and all, they excluded the patients who developed stroke or recent cardiovascular events within 3 months period. So within 3 months, we should be very careful.
True.
Yes, sir.
Right.
And about the hypertension,
Yeah.
Yeah, definitely decreases.
this will start also.
It correlates with the hemoglobin response.
Yeah.
Maybe sometimes 8 to 10. Usually adequate hemoglobin response 1 to 1.5 gram per month. If it's more than 2 gram, or we are achieving the target of more than 12, at the time definitely the patient will develop oxidative hypertension related cardiovascular events.
What about hyperkalemia? I tend to see a lot of hyperkalemia related to
With desidustat. Okay.
So most of them, the potassium is around 5.7, almost 6. All these patients.
You mean dialysis patients or?
Non-dialysis.
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 Cells can start maybe related to that.
Again, unless all these are tested out in a phased manner, these are all observations that all of us have, and all of us go by our own convictions. So now I'll ask Shiva to present his case. Where's Shiva? Here you go. Okay. Ram is on his way.
So respected Senior Professor Dr. Edwin sir, and all the senior and junior consultant nephrologists. Good evening one and all. I am Dr. Vasudevan, Associate Professor of Nephrology, MMC. At the outset, I would like to thank Sun Pharma team for giving me this opportunity to share my clinical experience with the desidustat in one of my patients. Thank you so much. Slide, please. Yeah. Next slide.
Vidwans come late for this.
So, role of desidustat in the management of anemia in dialysis dependent CKD patients. You modify the slides, no?
Second. Third. Already.
Modify, okay.
This is over.
So, these are the, yeah.
This is over. So also.
These are the clinical details of my patient. So, she is a 69-year-old female. She has systemic hypertension, coronary disease, and CKD stage 5 on regular twice weekly maintenance hemodialysis. Dialysis vintage is 3 years. She also has secondary hyperparathyroidism. So she has refractory anemia on the background of CKD 5D despite ongoing ESA and intravenous iron therapy detected on routine evaluation in March 2024. So the present illness, she is on regular maintenance HD for 3 years with persistent anemia even with the appropriate dose of darbepoetin and IV iron sucrose. In March 2024, when I evaluated her, the lab showed hemoglobin of 8.6 gram per deciliter with the normocytic normochromic RBCs in the peripheral smear. So typical of anemia of CKD. Her MCV and MCH are almost within normal range. So this indicates, actually I used to observe this MCV and MCH instead of going for straight away iron indices. So this will give a fair idea about the iron status.
You're right.
But even with adequate with the IV iron and darbepoetin, her hemoglobin was persistently low. Then I proceeded with the iron profile. So iron indices showed that serum iron is 129 microgram per deciliter, TAB is 277, the T sort of 64%. Ferritin is more than 1200 nanogram per ml. So already it indicates the iron storage is adequate actually. So it's more than recommended range actually. So according to the newer 2026 CKD anemia guidelines, this doesn't fit into either a systemic iron deficiency or restricted iron restricted erythropoiesis.
Iron overload actually.
So it is iron overload status. The serum folate was more than 20 nanogram per ml. Vitamin B12 it's adequate, and the serum IPTH is 280. Sees on Sinacals at 30 milligram per day. Then reticulocyte production index around 2. Fairly the bone marrow is okay. Sorry. Already explained actually. So during clinical examination, she had no evidence of active infection like chronic tuberculosis or ongoing inflammation. So she is not having any chronic inflammatory conditions. Of course, the CKD itself is a state of chronic inflammation, and there is no malignancy. So these are the current these are the medications that she was taking at the time. So apart from antihypertensives, statins, antiplatelets, and routine medications, she was on iron sucrose 100 mg IV once in 2 weeks as a maintenance therapy, and a darbepoetin 40 micrograms subcutaneously once in 10 days. In my practice, actually, I used to start erythropoietin 4,000 units weekly once. So if the patient needs, there is no adequate hemoglobin response, and the patient needs more than 4,000 units, I will switch over to darbepoetin 40 microgram once in 2 weeks. Still, there is no adequate hemoglobin response, I will switch over to desidustat. So this is my clinical practice I am following.
Patient was getting iron even with the T cell
Just a minute.
percentage and
They modified the slide and all. Medication, okay, secondary hypertension. Okay. Okay. So this is a case of CKD associated anemia with inadequate hemoglobin response. As you see, very well responded to desidustat. So after seeing the blood parameters, I have stopped iron sucrose and darbepoetin. Then I initiated desidustat 100 milligram 3 times weekly, and ferronemia. Actually, this one molecule, this will help in the mobilization of iron from the storage site. This is what the Lauren and company is claiming. That as you know, the desidustat, it reduces the hepcidin level and improves the T-set. The functional iron availability will be improved, and other inflammatory markers also decrease with the desidustat. It improves the endogenous production of erythropoietin. Actually, she very well responded to desidustat. The hemoglobin in March 2024, 8.6. After 2 months, it improved to 9.5. Then I increased the dose of desidustat into 150 milligram thrice weekly. Then the hemoglobin improved to 10.4. In August, actually, it progressively increased to 11.5. Then based on the hemoglobin response, I adjusted the dose of desidustat. Still, she is maintaining hemoglobin around 11 gram with 75 milligram thrice weekly dose of desidustat, and ferronemia and IV iron. Recently, I started 100 mg once in a month. So these things we already discussed. So this is the hemoglobin response. So in my practice, actually it takes almost 4 to 8 weeks for the initial hemoglobin response with the desidustat. Probably it reduces the inflammatory markers, then only the hemoglobin starts improving with adequate range actually. So generally after 2 months only we are expecting adequate hemoglobin response with the desidustat. So this is my observation. So currently the patient is on desidustat 75 milligram. There is no reported new cardiovascular events, no clinical signs of infection, inflammation or malignancy during the follow-up. So these are the my insights about this molecule. It's a safe oral alternative to ESA for both dialysis and non-dialysis CKD patients. It's indicated for ESA resistant anemia. It's an ideal agent for CKD patients who denied injectable ESA, and it's a drug of choice. Actually, I would say actually drug of choice for those people residing in remote villages. because the problem is cold chain maintenance and the supply of the ESA. So those individuals, this is a very good molecule actually. This is contraindicated malignancy, cystic kidney diseases, recent cardiovascular events, especially within 3 months, and proliferative diabetic retinopathy. Thank you for your attention.
Thank you, Vasu.
Yes,
My only thing is, again, compliance. So, an OP patient, how compliant they are. Say, you may prescribe twice a week. They may be taking only once a week for economic reasons, and you may be breaking your head as to find out why this patient is not responding. So, that is the compliance part has to be checked.
Yes. Actually, the cost is almost similar to darbepoetin, sir. If you give once in 2 weeks, 2,400 rupees, 100 mg thrice weekly, 12 tablets cost around 2,400 rupees MRP. Even if we give that number, no, the company person number directly, they are giving
Right. So,
800 to 2,000 rupees.
so economically, it is definitely viable as darbepoetin. Right.
Yes, sir.
So I saw that once you had gone up to 150 milligrams, the maximum
Yes,
dose
yes,
that
the
is
maximum
recommended
dose.
is 100, I think.
Sir, 150.
150.
So as per the recommendation, they are quoting 150 milligrams. 150 milligrams.
Now, if you look,
Thrice weekly. Yes, sir.
That 450.
Yeah.
no, if you go,
Starting dose is 100 mg, but maximum
Okay.
recommended
Go
is
up to
150.
150.
150. Right.
in the DREAM ND trial, what is the dose used?
They are using the same patient. They have started from the 100 mg.
No, but have they gone up to 150?
The number of the patient went to the 150 mg.
And one more thing, it should be given 1 hour before meals. Before food.
ND is non-dialysis patient.
Yeah.
The dream dealer they used 150.
This is a
This is a dialysis
Anytime
patient,
dialysis patient will
They require more doses.
higher dose.
Higher doses.
This product doesn't got any cytochrome interactions of the class of drugs. Cytochrome
Any drug interactions, sir. Drug interactions.
Other decidustat, for the decidustat, drug interactions are there.
Only this starting.
Yes.
So in fact, the KDIGO, this current guidelines say dialysis population screen only once in 3 months. But I think most of us would at least look at it once a month. The hemoglobin definitely we look at it once a month. Yeah, at least once a month minimum.
Once in a month.
Yeah, but even
Maybe it also mandates monthly KPA, hemoglobin.
correct.
Monthly hemoglobin KPA.
Yeah, that's what most of us do. But KDIGO says once in 3 months for dialysis population is fairly okay.
So our patients actually they have poor nutrition, sir. So we have to frequently change the interdiabetic, based on interdiabetic gain, the drivers should be frequently changed. So at the time they will come with the reports.
Correct.
Every month they will check the hemoglobin.
Yeah, that is routine now. That's routine.
I have a doubt, could we have tried 60 mg of darbepoetin?
60 mg generally won't use, ma'am. But it's available with some companies, Concord and CRISPR, so this is
Yeah.
But why use only 4,000 units per week?
We can
starting
once
dose.
in 2 weeks.
Starting dose.
Erythropoietin,
Generally start with the 4,000 units, then 4,000 units twice weekly we can use. So instead of going for 8 injections, better we can go to the 2 injections per month darbepoetin. The cost is also similar to the 8 injections.
How did you give 75 mg, sir? 50 plus
50 plus 25. Yeah, only 25, 50, 100 milligram. 3 strengths are available.
Question is, so this is a very frequent scenario we are seeing in patients who are on twice weekly dialysis, which is almost 75% of our dialysis.
Correct.
This high ferritin, high
Mm.
persistent anemia. Some of them do respond to deciduous-stat, but we do still see a group of patients who do not respond to deciduous-stat.
Correct.
And some of them, we have tried thrice weekly dialysis and we have had good response in those patients. How do we find out this subgroup? It's very difficult to
Only these patients need an inflammatory marker.
Look at the epsilon level.
Other things.
Little, not only.
No, but to say that my inflammatory markers are altered only by my deciduous-stat, again, saying too much.
Uncorrected anemia, sir. What's this?
Yeah, that is true. So one thing is one of the causes for resistant anemia is inadequate dialysis. So as I said, most of our patients for economical reason, logistic reasons, they are on weekly twice dialysis. So one of the reasons is inadequate dialysis per se.
So initially I thought of bone marrow fibrosis due to secondary hyperparathyroidism, but IPTH level was within acceptable range, 150 to 300 in CKD dialysis population. So this
patient was on Sinacard.
Yeah, Sinacard.
What was
But
the highest, sir, like PTH?
800 something. It has not gone beyond 1000. If it was beyond 1000, I lost for a systemic scan, terminal adenoma. This might click it back.
Okay. So thank you. Now we'll ask Ram to, yes.
Go there.
You don't have a pen drive?